Everyone, welcome to the 25th episode of Impression Club Live, and we've got an absolute treat for you tonight. We have got none other than Finlay Sutton coming on to talk to us about immediate dentures.
On a while that I'm really nervous for, but it should be an absolute cracker, so hopefully we can get Finn on nice and quick. Gary is straight in with the yas already, good man. And Finlay's online, hopefully we'll get him on soon. Hope everyone's doing well, usual stuff. Get your comments in, get your questions in, and we'll try and get through as many as we can. And we'll go from there. Evening, Mike. Come to see your boy. Perfect. And I'll just try and get it all in. We've had tons and tons and tons of questions, which we've already sort of organised through. But hopefully we can get through plenty of those and much more. It's dark already, which is just depressing, isn't it? A little bit of trouble getting it in. I think we're both requesting each other at the same time. Bear with us, people. Couldn't go too easy, could it? There we go.
Hello.
Good evening.
You okay?
I'm good. How are you?
Yeah, fine, thanks. Yeah,
Thank you so much for coming on. This is very exciting.
Connected to Finlay Sutton's MAIN MacBook.
So I'm just doing I'm getting it through a better speaker so I can hear you.
Ah, there we go.
But if it does do that, but it doesn't sound like it, but it's fine. It's good.
It sounds good now.
Yeah.
How are you doing? Good day?
Yeah, good day.
Clinical
I've not been treating patients today, apart from doing like video consults today and phone calls, and the dog. I took the dog to be groomed as well. So Fred is now nicely trimmed, and then picked Oscar up from school. So I've had a nice day actually.
Nice non-clinical. Are you still doing the looms?
Yes, I am. Absolutely. Yeah. So I've been doing Zooms today with the patients, and also I do the looms for the patients too. I really love them. So I might talk about that tonight, actually, Rupert.
Yeah,
but how about you? Do you do it?
I don't do looms. Nick's using it quite a bit at the moment. I think he quite enjoys it for similar, as you say to yourself, it makes it stand out a little bit more, and it's a bit maybe clearer than the block, especially if it's pulled out of SOE or whatever and it's got lower right 7 and whatnot on it. But I need to look into it a little bit more. And Jazz straight in with loom is awesome. I know you guys covered that. I think that was the top tip on your episode that you guys did together, wasn't it? Yeah. But yeah, I'm sure that will come up in communication. We've got loads of people coming on, which is great. So we're going to chat tonight about immediate dentures.
Yeah.
As I said to you before, slightly vested interest in that. I've been trying to get on your course for this for ages and I couldn't, so I thought I'll get you on live instead. But I think as anyone who sees your resources and things you put out in your newsletter, it's something that I think you just cover really, really nicely. So I think I'm really excited to have you on for this. This is great. For anyone who lives under a rock and doesn't know who you are, could you just give us a quick little introduction and then we can jump straight in?
Okay, I'm Finlay Sutton. I'm based up in the northwest of England, and I am a prosthodontist, really. That is my day-to-day job, doing dentures. And that's all I do clinically and have done for getting up towards 10 years now. And I truly love it and love what we can actually do for, transforming a patient. And just it actually can just give them a whole life back. And actually, I do think that dentures are really fantastic solutions to missing teeth for so many patients. Even in this day of implants, and implants are fantastic, but I do think that great dentures still have a place to play and can look amazing too.
Absolutely, I'm with you on that one. And with your practice, it's got multidisciplinary specialists, right? So it's not just a one-stop shop for that.
That's right. Yeah. So I do the denture work. there's a prosthodontist that works there called Zoe. So he does the fixed prosthodontics. And then we've got a periodontist that's Saeed, and we've also got a endodontist, Rob, and finally my wife, who is a orthodontist. So there's 5 of us clinicians that work at the practice.
You've got the dream team. It saves you doing AGPs as well.
Absolutely. Totally. Yeah, I don't even know what that is now.
You're sounding like Mike. He retired from AGPs as soon as he did one, I think.
Yeah.
So I think the overview that we're going to look at today is we're just going to try and sort of go through the whole sort of sequence. And I know you've got a few cases that you want to sort of put together and things like that. So the first thing we're going to chat about is sort of assessment, treatment planning. Obviously, I'm assuming you get plenty of referrals in and things like that. So, you know, a typical new patient assessment or referral assessment, what does that look like in terms of pre-tests and things like that? Or what do you look for from your referrers?
Well, I've got a really great referral base fairly locally. So I just get a patient referred in. Actually, what's really quite interesting is that's changed more over the past year or so, and I probably get more like 70% self-referrals. You know, patients just contacting me directly, and it's 30%, you know, referrals from GDPs. But anyway, yeah, the patient gets sent in. I always do either a telephone consultation or a Zoom, and generally it's more like Zoom. 70% is Zoom to start off with, and it's brilliant. And we record this for the patient. They'll be sitting in, you know, in the privacy of the home. They'll take the teeth out, show me. I can do a screenshot of it. They can just do that up to the camera, and I tell you, it is amazing how quite accurate I am in terms of knowing what that patient needs to have done, even from that. But it really gives me a really nice introduction to the patient. So from that point, I can give them a really good idea on what might be needed and also how much it's going to cost. And it's a great filter. So quite often the patients say, "Oh, that's just way out of my ballpark," and it just means that there's no wasted time for them coming in, me having to write a report, etc. So I find that really good. But if the patient is interested, then we get them in, and then I do the full examination. You know, take all photos, look at the teeth. I'm really wanting to know what their wish list is as well. What do they really want to have done? And the longer I do this, the more patients are sent to me for dentures. So they're already been through that sort of choosing, thinking, consent process of should I do implants and have fixed work, or should I go down the denture route? Quite often they've sort of self-filtered themselves to that. So it doesn't really take. You know, I talk about those choices, but we can quickly cross them off the list because the patient's already thought about it. I think really the main issue that I have is knowing which teeth to keep and which teeth to take out. And so I err on the side of keeping teeth if at all possible. And then incorporate into my chrome denture design, you know, my partial design, a way of adding onto it, so we can add onto it in the future, so it's future-proof in that way. So they're my real sort of principles. You know, if you've got a wobbly tooth, for instance, that is causing no issues for the patient, then I just keep it if it's useful, and often we can get those to sort of stabilize and become more less mobile with these nice braced partial dentures that we do, which are a bit like splints to hold everything together.
So what is for you then the cutoff then? Is it pathology and pain essentially are the two sort of?
Yeah, it is. It's pathology, pain, restorability. You know, has it got you know, loads of caries? Because quite often, you know, root caries, you see these big lesions coming in, and then they're almost like it's like a tree that's just been chopped down. and then there's very little left. So, but even with that, quite often I'll be saying to Rob, who's the endodontist, let's root fill it, let's just fill that cervical lesion and keep the thing for longer. You know, even with a crown, or even just decoronate and keep it there, retaining bone, etc. But overdenture abutments do add more complications. As, you know, they, in terms of the actual denture itself and the fit of it, you know, you've got the flange, you've got the alveolar mucosa there, and the denture sitting on top. So overdentures they're quite tricky and complicated, but are super as well if done really well.
Yeah, it can be a good transitionary sort of option as well, particularly if maybe it's a younger patient trying to maintain some bone or those kind of things.
Absolutely. So once I've actually seen that patient, Rupert, I do a really detailed plan. I'll just flip my camera around now. How do I do that? Oh, there we are.
Awesome. There we go.
So this is the type of letter. It's, you know, partially you can see it there, and it's really detailed, and it's got the diagnosis on it, and then, you know, what's going on with the patient and what we can do with it, and also everything they need to be aware of associated with, you know, if they're going to have dentures, because, you know, I just like to under promise and over deliver on these sorts of things. I want the patient to be really aware of what the limitations are, and also what they're letting themselves in for in terms of time, time span. So, and actually I do if I just have a look on here, I've got a sheet that I do, a treatment planning card, which I think is dead important and keeps me right, but it's somewhere.
Oh, like a guide for yourself, you mean, in terms of
that's
how
right.
to...
Yes, yeah. So it's somewhere further on in this presentation, but we'll come to that later. But I think it's dead useful.
So in terms of that, that's the bit, as I mentioned, as resources you did before. I think it was the case before last was an immediate case, and everyone was like zooming into the into the plan to sort of look at this like 10-page letter. But you know, I think that was one of our sort of questions, sort of later on in the process, was about communicating on the day. But obviously, communicating this beforehand, which is what you're doing with this letter, is, you know, how are you going through with the patient, sitting them down and saying, we're going to take out this tooth, this tooth, this tooth, we're going to do this, and then it's going to heal drastically by this point, and it's going to heal slowly to this point. We're going to need to do, you know, X, Y, and Z relines or replacements or whatever. So how do you sort of go around that with the patient?
I think let's play it like this, because, okay, Rupert, you're the patient sitting there in the surgery, and we're going to do, say, a clearance of the upper teeth, So yeah, Rupert, what we're going to do is, the stages that I like to do this are, what we do is we get a denture made ready for you before we take the teeth out. And by the way, just as an aside, I very rarely do it in staged extractions, because generally the teeth are just so short, they just need to come out. And it's better, I find it's better just to take them out in a oneer and just get that sort of horrible appointment out of the way, rather than staging it. But anyway, so yeah. So what we're going to do is we'll take all of your teeth out, but we'll have a set of teeth. And I have an example sitting there in the surgery, and I'll show them, and it will look like this, and it will fit that at that day of appointment. Now, when we fit it, it's not going to fit very well. And you may actually find that it has very little suction on it when you walk out of the surgery. So quite often at the consult, I say to them, look, imagine you are here today to have all of your teeth out. This is what's going to happen. So I'll get you numbed up. Claire's going to look after you. We'll take these teeth out really gently, and then we'll fit the denture. And the first week is going to be the most difficult week for you. You know, you'll be needing to adapt to this denture. It's going to be sore where we've taken the teeth out. So eating and chewing is going to be difficult. So it's going to take some getting used to. But once we've fitted that, I'll be reviewing you. I'll review you a week after, and make them as comfortable as possible. And then during that first 2 months, I may put some material in it just to make it fit better because the gums shrink away. And generally, Rupert, I do a reline chair side, so in the chair at 2 months after extracting the teeth.
Yeah.
So, and then moving forward from that, so 2 months to 4 months, I'll do a hard, it'll be a lab reline. So your denture will go through to Rowan in the lab there, and he will reline it. He'll get it at 10 o'clock in the morning, and it'll be ready for you at 4 in the afternoon, and we'll fit it. And then after that point, you'll be in a stable holding pattern for the next 9 months. Now, so if we just ignore the fact that you're the patient now, we'll just get back to sort of like talking dentist to dentist. I never do an immediate denture on its own. It's always part of a plan. I regard an immediate denture as a temporary. It's just a temporary thing, because I find there's so many things that are just not right with that immediate that I could really never change and make it really, really good. So I always take the patient on and say, we're going to be doing a temporary first, and we're going to be doing the final denture later. And this is part of the whole package. So the patient pays for that whole package. So the patient never goes away with this immediate and then comes back a few years later with this horrendous mouth or something that's, or a cracked denture or broken, and really having an SOS time. So I do find it's better to do, much better to do it as a in that way.
And be completely upfront with it. Is that that's in the letter? Then I'm assuming
that's in the letter. So they're paying for this whole process right from the beginning to the end. So it's not either, they're not just getting an immediate, they're getting the whole thing sorted. So so I start the definitive 9 months after extracting the teeth, generally.
And then that as well, as you say, particularly with a full clearance, like you said, there's always going to be some sort of compromised way of putting things. A lot of the time you're going to put the teeth in more or less the same position to help the patient transition and things like that, which is going to cause you loads of other issues potentially. And so it's being upfront with it and just putting it out there is the way to go.
Absolutely. Yeah, definitely. Yeah. So, and it is really, the sort of communication to the patient about the limitations of this is really, really important. Because, and also I think really is, young dentists, any dentists that are out there, that you're just thinking about doing an immediate, try to imagine what that mouth's going to look like once the teeth have gone and a year down the line, because sometimes there's no flipping ridge left and you're left with a totally flat maxilla and very little retention. So it's really thinking what is going to happen, and also trying to explain to the patient that this, you may have, really look at the muscle attachments and how high they are in that mouth. Are these going to compromise the peripheral seal later on down the line? So it's really, communication is dead important.
And then one of the other questions that we had, I guess, which is going to come into this stage in terms of planning, was about sort of number of appointments. Are you doing some on multiple stages? If they're already missing some teeth, are you doing as many normal stages as you can, and then essentially adding the immediate teeth on after a wax try-in? How do you sort of gauge? Is it going to be a one-step job? Do you ever do a one-step job? How does it look for you?
So occasionally, it's very much if the patient has, it's really dependent upon how many missing teeth that patient has. So, for instance, if we've got a patient who's needing to have a full clearance in the maxilla, say they've got massively periodontally involved teeth, they're just wobbling about, but we're going to take all of them out. it can't really be done without just doing one impression. It's just one impression, go to finish.
Yeah.
So, but if you've got, say, one tooth or a few teeth there, then all of the stages of complete dentures can be done to make that denture better. So, like doing your primaries, definitive impressions, jaw edge, try-in, and then fit. So it's very much dependent on that. So it can be a bit of a compromise between two. So if you've got quite a few teeth that need to come out, which means that the definitive impression is useful. So I'd do a primary working model, so working impressions, jaw edge, and then go to fit without bothering doing a try-in, because quite often the teeth have erupted down all over the place. So it really is, it ranges from one hit go, a middle road, or almost a full denture road, depending on the numbers of teeth that are there that are present.
And yeah, is it mobility and how many imps you want to take of them without risking extracting them earlier.
Absolutely, yeah.
So on that then, I think the next thing people want to cover was sort of impressions, your tips for that and things. So when I had Mike on a while ago, we talked about doing sort of for the anterior mobile teeth, and how you've taught it as well, doing like the multiple stages there. But I mean, if you want to go through that as well, that's fantastic. Any other tips for sort of immediates? And then what was the other question? It was border molding where there's teeth still and things like that.
Yeah, I think let's have a look at that, shall we? I'll just flip my screen, and then I'm going to go to a slide. Let's have a look. This person here.
This case.
There. So this is Donna here. So and Donna's going to have all of her upper teeth out there. So all of those maxillary teeth are periodontally involved. And so in terms of the impression, it's just a one hit with these. So let's have a look. This is the upper one there, which I think is better to look at. So what I'm trying to do, and with removable prosthodontics, it's the only part of dentistry where what we're trying to do is record the sulcus, a reflection of the sulcus. I don't think there's any other branch of dentistry, Rupert, that we have to record the sulcus in. So, but it's crucial for our dentures. So what I'm trying to do is just record this full depth of the sulcus. Now, and then Rowan actually makes the denture so that it's about 2 millimeters short of that full depth. Maybe not quite 2 millimeters, 1 millimeter short, but it's so Rowan finishes that the denture, and that's it here, fitted, and so it's what I'm trying to do really is first assess, if we go back to this, if those teeth, if I think I'm going to pull those teeth out when I'm doing that impression there, then I will block out with Futar D into these areas. If they are ultra mobile, I'll do a two-part technique, which I know that Mike talked about as well. But with this case, with Donna, I could just do that.
And this is injection alginate, isn't it? This is sort of a bit like the some of the R-based stuff that you see as well, isn't it?
That's right. This particular one's Ivoclar Vivadent, and now it's made by Zermac, Zermac neocolloid and Tropicalgin. You put it into a syringe. The orange stuff goes in a syringe that gets injected into the sulcus, and then the blue stuff is like a base material. So that's that. And what we're trying to do is actually that with this case here, she had missing lateral incisors. So we copied that in the actual immediate denture just there. So and it's great. I love doing this sort of thing. It's brilliant.
So in terms of that injection technique, then, and
Yeah,
as I say, that's your way of border molding around these teeth. So can you just run people through that, because it's not real. I don't think it's overly something that's that taught undergraduate level, at least.
yeah.
So say you've got it's a more sort of flowable textured alginate in the syringe, and then the
Yeah,
sticker in a tray. Yeah.
that's right. So it is. And so you've got a really big syringe. I think it's about a 35 milliliter syringe, but it's just a monoject syringe. So the light bodied, I think it's a neocolloid actually. Neocolloid goes into that. And then the tray, we just have a normal stock tray, which is loaded with the base material, the thicker material. And so I have those mixed ready at the same time there. And what I do, literally just pull the sulcus back and squirt the material up into the sulcus all the way around. And Claire has these two little retractors just pulling the lip forward. Do you use those?
I can't find the same ones that you've got, because I keep wanting to, and all the ones that I have, I've tried loads of different ones, and they all just get in the way.
Do they? So I've cut up some photographic retractors
From the half ones.
Yeah, just and I just pull it forward. So I just inject that up into the sulcus, and then what I do is I get a little bit of the runny alginate on my finger and rub it into the biting surfaces, so the orange stuff gets rubbed into the biting surfaces, and then I get the tray and fit it at the back of the mouth and rotate it up at the front. Second, just push that in, a little bit of border molding, but you know what? And I think this is really important. If we're making an immediate, doing green stick border molding around the teeth there is just not going to do anything. It's border molding has no real benefit for immediates at all. Border molding is brilliant when you've got no teeth there and you've got a lovely saddle to mold.
Zanizo Sadiq missed Mike's episode and has asked, how do you do a 2-step impression for ultra mobile anterior teeth?
Okay.
Do you want to go through that, or shall I just
yeah.
them to Mike's episode?
Well, I can actually just what I'll do is I'll just quickly find it, because I've got the technique here, and
so I did literally the week of doing that episode with Mike. I actually had a case that I did it for, and it worked. It worked nicely. It definitely takes a little bit of practice, I think, to get it slick and going well. But yeah, it was good. Here we go.
So here we go. So this is Joe, and so like loads of some of these teeth are really going to just come out in the impression. So if we move forward, so I take a stock tray. And if you see there, I've cut out the labial part, the labial flange, if you will, of the tray, putting some compound in the middle there. And that compound is dead important, because I can warm that up and I can then position that really nicely, for the patient. I'm just going to make sure the sound's off on my laptop here. So what I do is I rotate it in for Joe here and sit that up onto the palate. You can see Claire's just had those little retractors in. Just let that set, just like that now. And then I then take that out. So the actual, sorry, I'll just go back one step. The tray looks like that. So that's how it's going to look. And now then what I do is I use the alginate. So here we go. So I'm going to rub the alginate into the occlusal surfaces of the teeth, and I've got the tray loaded, and you can see I've got that window missing at the front. The labial flange is not there on that tray, and I'm just going to push that up gently into the mouth there, but not run it round the outside aspects of the teeth themselves. And then we just wait for it to set. Again, I'll just go on, Joe, do a little bit of a waggle for the coronary process. He's going to have a complete upper denture, this chap. So so it looks like that in the mouth there. So, and I just gently bob that out. And what I've done here, I've just cut little grooves in just there and there, and so that means I'm going to reseat it, but it's going to help lock in this new material that I'm going to squirt in. So this gets put back into the mouth, and I think a little detail here, Rupert, which is dead important, is quite often sometimes these little embrasures, we've got these little embrasures there, it stops it from seating properly again, the actual the impression back in the mouth. So quite often I'll just scoop those out, with my Lacron to get it to seat. Goes back into the mouth like this, and then using a heavy bodied silicone, I inject that into the sulcus because I want to record the sulcus depth for this patient here, all the way round. So that gets injected all the way round the whole of that sulcus, and then I take it out once it's set. So I undo that labial aspect, take out the bottom bit, and it comes out in two sections, and it avoids pulling out these mobile teeth. So this is heavy bodied. This is actually a Shotlander product, heavy bodied silicone, this purple stuff. Just gently undo that, take it out, and then it comes out like this. So we've got two bits there. That's the bit, the impression of the palate and the occlusal surfaces. This is the labial aspect, labial sulcus. And then if we have a look at the impression itself there, we can glue it back together. I'll just show you the occlusal picture there. So what Rowan does, he dries it off, and then he uses super glue to glue all of this labial bit on here. So then we can then produce a working cast on which we can then plan where we're going to position the teeth, using these photos, and just extract the teeth and go for it. So
yeah, that's another cracking case that you need to check the resources out for, guys.
Yeah.
What was again? Oh yeah, Mike. So Mike's crediting Linda from the infamous Bestford Club, for teaching him the mobile teeth technique.
Okie dokes. Cool. Linda
So
is amazing.
Hopefully that answered that though. Any other sort of impression things there? Obviously, well, you've mentioned there about the notches as well. That's really important to help Rowan or your technician, whoever's doing it, to locate everything back together nicely. In terms of redging mobile teeth and things like that, do you just do a conventional sort of silicone bite for something like that and think that it'll be close enough even if the stuff moves around?
Definitely. So what I try to do is I just record them in ICP actually. So getting to and using futar just between the teeth, and often when Rowan is mounting them, he'll find that maybe an over-erupted tooth, or you've got mobile teeth that will just, like, as soon as the patient bites together, you're going to get this fremitus, and so the actual cast will be different than the mouth itself. So if there's any teeth that are sort of extremely bad, we'll just trim that down. It'll just grind that off and try and get everything to fit together better, and then articulate it once he's got something that looks like it's articulating reasonably well. And you know what the beauty about taking loads and loads of clinical photos are, he can say, look, Finn, I'm just struggling to get this to bite together properly. Could I have a look at the photos of the patient? So we just look at the photos together from front on side views and see if we've got it lined up properly, and then work like that. Because they are just temporary appliances, these things, and so when we come to do the definitive, the final, I record it in centric relation always, for full dentures. But for immediates, I use intercuspal position generally. If there's lots of teeth still present, if there's very limited numbers of teeth present, then I'll go for CR in those cases.
Perfect. And were there any other things in terms of impressions or anything like that? I mean, do you do any scanning or anything like that for particularly, certain cases or anything? Have you ventured into that yet?
No, I'm very much analog still. so, um, so no, I've not ventured into that because I don't at the moment. I just don't feel that the benefits are there for it. And doing these two-part techniques are really, really terrific. And I find that you can do these two-part techniques with special trays as well. If there are just a few teeth remaining, we can do like a window, almost like a flabby ridge impression where the teeth stick through it, and I can do all the border molding really nicely. So I can accommodate really wobbly teeth and get good sulcus impressions, and they are more accurate than scanning at the moment, but it definitely will come in, I'm sure.
Yeah, I've done a couple where I had one where it was similar to that chap you just showed, multiple mobile teeth, and I just didn't back myself to be able to do a good enough sort of impression, and it was only an immediate for 3 incisors. Everything else was sort of sort of grade 2, but as I say, sort of nursing along, never denture wear and things like that. And for that, actually, the patient was so worried about having an impression done that the scan actually worked quite nicely. And the only thing that had to be adjusted was labial frenum, because that was pulled out of the way when you're doing a scan. So that worked quite well. Just had a question pop up. Does Finlay run any courses? Yes. Do you want to tell us quickly about those while we've had a question about it?
So
just in case they're not on.
I do four courses. So complete dentures, and one on immediate dentures, one on partials, and one on implant overdentures. I run them from here in Lancaster, where I get a patient in, and we have about 10 delegates, and they watch me do all of these techniques. And the wobbly teeth impression, I don't have patient. I can't get a patient to come in for that, so because it's just not the right thing. So I use Claire, and we imagine that Claire's my dental nurse, and we imagine that Claire's got super wobbly teeth all the way back here, and then we do that two-part technique. So yeah, I love teaching. It's great.
Perfect. So in terms of then the last sort of bit is sort of the day of fit reviews and things like that. One of the questions that we had, I guess, is slightly before that in terms of, there's a few actually about design. So one was flange versus flangeless scallops, things like that. What are your views on that?
So really, if we've got, say, a partial denture and we're taking out some upper anterior teeth there, then I don't do a flange, like a big flange on those. Generally, it's more scallops, but with pink work high up. So actually, I've got a case I can just show you that now. So I'll just bring that up. So I think I do very little adjustment to the cast. I think that's the really important part of the whole thing. Is so let's just go for 88. There we are. Press play to do there. So that's just this is actually a duplicate of my of a cast. We're going to take out these 4 teeth just here. And so when we prep the model, we don't do a lot of preparation on that. You can just see we just scallop out the teeth, literally scoop them out, almost like if you had like a crown preparation, there with a removable die, and then the denture itself looks like that, and Rowan just pushes the pink right, so it's got white teeth but also the pink gum tissue high up. In terms of prep, we are doing about 3 millimeters depth, scooping out, and don't really do a lot there because we really don't know what's going to happen when we take the teeth out there.
And is it something are you talking radiographs? Are you sort of, because you can sort of base a little bit off sort of bone levels and things like that? Is that something you communicate?
Yeah, you can't. Yeah, so when I'm doing this, often I'll have the X-ray pictures up, sitting with Rowan, and we've got the models there, and also the photos, so we can actually just gauge what's going to happen. We don't get it right all the time by any stretch of the imagination sometimes, and so at the fit appointment I've got to sometimes do a bit of work to get around this, but I'll talk about that just in a sec.
Yeah.
But that's this is like our standard design really for like an upper immediate there, and I just take the teeth out as gently as I can with I really like luxators actually, you know, for just extracting the teeth, and you know, you never know what's going to happen. Sometimes you get this ankylosis, don't you? You know, with this bone stuck on, and quite often you'll get a big chunk of bone that just it means you've got a big alveolar defect. And in those cases, I do use Viscogel, you know, to just fill in any gaps afterwards. I love Viscogel, and I mix it nice and thick there. So that's the overall design. I'll just want to go back to another case that is we've got 48. I'll just go back because this is where I didn't get it quite so right in terms of there we go. So here's Mandy, and I'm going to just take out these upper 2 to 2. You can see there's massive over eruption of that anterior segment.
This is a tricky one. Connection getting a little bit funny. Sorry everyone, bear with us a little bit. Hopefully get Finlay back soon. But yeah, if you've got any questions when we do get Finn back on, keep them popping up in the group, in the chat. And we've lost Finlay. There we go. Don't worry, I'll get him back, guys. Sorry everyone. Hey, we're back.
Hello.
Take 2.
So I'm just going to flip that. So back to, so here we've got Mandy there. So yeah, this is what we're doing. So we're going to take these 4 out just there. And no, so this is the dead important, the whole point, the more communication we can have with the technician, the better in terms of getting good results with these people. And so this is where where we've drawn on the cast where we want the teeth to go. And ideally, so, and this is so over erupted here, it just doesn't look great. So we've drawn what we think is the ideal incisal plane for the patient, and also the ideal zenith here, you know, of the gingivae. So, and then Rowan then prepares that model. And sometimes with these cases, if we're having to really lift the teeth like that, I might need to do some bone removal or some soft tissue surgery, thinning it down when I actually come to fit it. So this is the immediate denture made for that patient. We also did these for the lower. She's got these over erupted lower incisors there as well. So, and Rowan did 3 in that rather than trying to fit 4 in and make them look silly. So 3 lower incisors can actually look really good in these cases. And my rule of thumb is 2 clasps per denture as far back as possible. So these are stainless steel clasps as far back as you can go because they're out of sight, as further back as possible, collated all around the teeth. So this is what, and then, so when I actually took this tooth out, these were like, came out lovely and clean, but there's a big chunk of bone came with this one here. And so, and there was actually, what I'm thinking about as well is that when I'm fitting dentures is when I come to fit them, I don't touch this area here, that the edge of the collet is just so important. Just keep away from that. And so I'm just fitting it here. This is off a video that I was taking from my loops, and it just didn't sit down very well there. Can you see how it's just not sitting? So in this case, what I did was thin out this tissue here. So thin it really down, because that incisal papilla was really bulky and thick palatal tissue. So I just used a blade just to do that, and then just some interrupted sutures just over there, and then just making sure this denture can just seat properly. I love using this stuff. It's occlude. It's a spray, and it just helps me to know that it's seated properly, and where it rubs off on there, I just adjust it with a handpiece.
As you say, not from the sort of palatal aspect of the collar.
That's right, not from where it touches against the tooth, but anywhere below this area, I can adjust it freely, and it will not create a gap underneath there. So let's just see where we're at, and I noticed that I just still couldn't get it to sit down properly. I'm using like a silicone here to just see what's holding it off. And then I realised that my impression was not very good. Can you see I've just not captured the palate properly here, just in those areas? And so Rowan's tried to compensate for that, but it's actually the palate that was really holding this off here. Can you see how it's pushed away my silicone there, and it's holding off? So I just use a burr, tungsten carbide, just to drill that down so that it then just starts to seat better. But
it's a super handy tip for fitting immediates in general, isn't it? Because particularly front teeth, they're numb, they don't know where it's hurting or where it's too tight. It's
absolutely
really handy. Yeah.
Dead important. And then if we go to looking at the actual thing there, I still had this gap here. And so when that happens, what I do is I fill that with Viscogel. So it's I put some wax on the outside here to stop the Viscogel from going into the embrasures.
Yep.
And then load in. Really, this is thick. I don't use the manufacturer's instructions. I use loads of powder and not very much liquid. So it's thick. And then push that in there. So it just forms a nice flange on that. And then just wait for that to set. Just gently pulling it in and out. Really
and is Viscogel what you're using for your 2-monthly reline as well?
No, Ufigel hard.
Ufigel, yeah.
Yes. Yeah, so that's that here, like that. Now, often with these cases too, when I'm doing when I'm fitting a denture like that, particularly if we're taking some anterior teeth out, often there's very little space in the bite. So
I was just about to ask you.
so often in these circumstances, if we thin the denture out too much, then it will be so fragile, it's just going to snap on that front edge. So what I do is I just accept that we're going to jack the bite open and then just wait for that resorption to take place, and it's absolutely fine further on down the line, because we get space created where there's
underneath
the resorption, underneath.
One of the other things as well, people are asking was about lingually inclined teeth, and I'm going to be again slightly selfish on this because I've actually got a case coming up and my technician's got it on his desk at the moment, thinking, how am I going to do this? Where it's replacing anterior teeth on the lower, all the posteriors leaning inwards, and we're trying to work out a little rotationary or something. But how are you assessing things like that, and any ideas on getting around lingually inclined teeth?
So what teeth do they have? We've got missing lower 3 to 3, is it?
They will be missing lower 2 to 2
Lower 2 to 2, yeah.
and a lower left 4, but the lower
Yeah.
left 4 is out of the arch buccally, so we're probably not going to be replacing it.
Yeah.
But she'll be 3 to 7 either
Okay.
side going backwards.
So in those circumstances, what I'd do is I would just, if possible, and if the patient's happy about it, just do some grinding, odontoplasty, if you will. If they sounds better when you say it like, but just makes, so you're actually just reshaping those lingual surfaces of the lower teeth, if it is possible. But I'd have to look at the case actually, because there might be some really quite interesting ways of approaching it. You could potentially do like a 2-part denture, where you get a chrome framework that goes in with a
butterfly.
Yeah, with a bolt on it. Yeah, or a butterfly or something. Yeah, that's interesting like that. So, but generally, I try and keep things super simple though, Rupert. Really.
Yeah. Exactly.
If it's up, I'd just be looking to reshape if possible, and that's actually quite often if you've got to do multiple surfaces. That's where these little Duralay hats come in with the window, with the part of the tooth that you need to shave off sticking out, and you can have it on multiple teeth and just shave them all off, and you know that they're all parallel because the technicians help to produce them, those prep guides, if you will. But I know that's probably a little bit confusing to some of the audience, but it's on some of my presentations if you look on the results.
There we go. There's the plug. Gets on the resource. So essentially, you're sort of designing it the same way that you'd, with a chrome, you'd maybe say send off that primary cast and say, where do we need to put breast seats? Where do we need to adjust guide planes? Exactly the same thing.
Absolutely, definitely. Particularly if I'm sectioning bridges and fitting an immediate, then these little Duralay hats that go on that are parallel, I can just shave the pontic off at the parallel to the guiding surface that I'm wanting that denture to fit in. It's really neat, actually.
I find bridges particularly the toughest. I don't know whether it's about I did a case recently, a referral case, always the way, isn't it? But a really tricky one where it was 6 to 6 bridges, essentially, for a full clearance. And there's just so much more guesswork going on with the underlying mucosa and things like that. Do you have any tips about that kind of case, like a full bridge work?
Yeah, it's all about the impression. So and particularly the 2-part technique can be brilliant with that. Where you get right under the pontics. So if you can record that soft tissue under the pontic, then they can come out beautifully. So you've got this, really, really well detailed impression of that fitting surface. So yeah, the 2-part can really, really help with that.
Yeah, so it's not just for the mobile teeth.
No, actually, yeah.
Yeah, that's good. That's a really good point, actually. Because you're going to be able to get underneath that and then have it around, whereas a straight over the top is going to rip out.
Yeah. So if you have, say you get your palatal part in first, really well in, and sitting nicely. Don't bother taking it out. Just leave it there. But you get your silicone heavy bodied, but really inject it labially in all the way around and get the lips and push it in like this, so it squidges underneath the pontics and touches your alginate on the inside, and then peel it off and fit it all back together. It's cool.
That's a good thought. So then, day of fit, we've sort of already covered a little bit there, but and you sort of said it at the start as well in terms of the consent. Obviously, the key thing is even with just LA, you've put liquid under the tissue, so you've already altered the fitting surface. Palatal infiltrations for a full clearance.
Yeah.
It's not going to be anywhere near the same.
No, it isn't. Absolutely, it's all boggy, it's spongy. So I think what's really important as young dentists to understand is that the technician may have made you a superb denture that's going to fit really well, but when you try it in that boggy tissue, it always drops out, and it's always disappointing. You feel, and so it's really important to discuss it with the patient about what to expect. So, and that's where the loom comes in actually. So, and I'll just find that I think looms are the best thing for patient information after they've had the teeth out. They're brilliant. So I'm just going to find the bit here. I'm not going to put it onto. I'm just going to. So I'll just flip my screen. So this is a software that I use for talking to patients with, and this is a case that if I'll just put the sound on here so you can hear it a little bit. Some lovely TLC from Alex, and you're just resting up in bed with you. But by the way, this is a actual loom I did for a lady that I did a full clearance on, and so what I do is, once I've seen the patient, I'll sit with them in the surgery and go through a list of instructions. But as you know, I know when I go, I've had like operations, and then the nurse will come and sit there and tell me loads of information. It just goes, whoosh, and I forget everything. So what I do is I also do a personalised video for them, and it takes they take about 10 minutes to do for it. But I think it's just so nice it being personal for that person. You could do a generic one quite simply though. But anyway, this is the one here that I've done for this lady, and just looking after you. So you did beautifully today. I'll just show you a photo of what your teeth look like just now. I know there's a little bit of blood there, but they look really superb, and I was delighted with how well they fit actually at the moment. It's when we come, and there's always like an element of unknown when we take teeth out, knowing what it's going to be like underneath in terms of the fit. So they just fit beautifully, and I'm really happy with that. And you did so well with the procedure. It was terrific, really dead easy to work on, and it went perfectly. It was textbook, really good. So I'll just run through these instructions. So I go through all those instructions. Just take the medication here, that the ibuprofen, paracetamol, 2-hour intervals between. So that is, sorry, I'm not going to bore you to death with all the details, but again, you can just get this off the website. These list of what the patient's going to anticipate and expect. But I do say that at the moment it's going to feel loose, but it will get better as the week goes on. It's going to be very sore. You must not take it out. It's got to be in 24/7, and this is why. And so when I'm actually fitting, say, a full denture, I really do check with that green silicone wash if it's rubbing anywhere, particularly on the labial aspects, and I'll adjust that to the point I feel it, so it's not going to be too bad. But again, that's sort of an experience thing, but it's generally just on the canine eminences.
Yeah, that's what I was going to say. It's always the canine, that big chunky bit.
So and then just learning to eat, chewing with small bits of food, becoming a chopper, not a grinder, with all of these different things. And I insist, I'll say, look, you must have at least a week off work, and if possible 2 weeks, because it's such a big deal for these people, to help them just to get used to them, get used to the feel in the mouth, and become more sociable. Some people, but everyone's so different, aren't they? When we're treating these people, some people get on with it like amazingly, and some people it's the worst time of their life. So, and actually picking these patients, it's quite difficult. I still find it.
Mm-hmm.
You know, sometimes I think, oh, this patient's going to be really phlegmatic, and they turn out to be nothing of the sort. So, I think it's really under promise and over deliver is really, really important with this.
Yeah, absolutely. I think, for me the silicon fit test, I can't remember which of your lectures I saw it on, but that's like an absolute game changer. So since I've started doing that, you know, hardly ever any issues with immediates. I did a post about it this week or last week with the silver stuff, if anyone wants to check that out and see what we're talking about. But as I say, it's always that canine eminence is always the worst spot. So you're reviewing it 1 week?
Yes.
Yeah. And then any particular things that you're looking for at that point, either good or bad, and how to go around changing that?
Basically it's I ask the patient how they're getting on, and do you know what? With doing these loom videos, this is the important bit. They're much more primed. They say, "Oh, this happened," and I knew you talked about it in the video, so I rewatched it, and then their sort of experience of it is much better because they've almost got me there to help them along, get along with it. So, but anyway, generally it's going to be rubbing in some area, you know, really sore around some root eminence there. So what I do is I will adjust it, and quite often, I think it's really good to keep hold of working casts. This is where we are totally different than most dentists. Most people don't, and technicians, the working casts just get destroyed when the denture's being processed. But Rowan doesn't do that. He keeps the working model and then makes the dentures on duplicates of that working cast. So I've got mounted models on an articulator, and often because it's so sore under these areas, I don't want to put pip on and try and pick it up because it hurts. So I look on the mouth and then translate it onto the model and just draw a pencil mark on it, go into the lab and then just adjust out that fitting surface so that it's not as sore, but trying to still preserve that flange so I can still preserve that suction. So it's just about making them comfortable. So getting them really comfy, often using that silicone afterwards. I'd adjust it roughly first and then use silicone second and just a double check. And then thirdly, I do look at the occlusion then. I want to see what's going on with the bite and adjust that to make it even just when they're close together. I'm not looking
because a lot of the time that can be a sore spot, a reason for the sore spot rather than necessarily rubbing.
It can be, yes, absolutely, yeah. So the occlusion, all I'm looking for is nice even contact in centre, or where just closing together. First point of contact needs to be on the premolars, both sides. And that's it. If it's a full denture.
Perfect. And then one of the bigger questions we had later on was reline protocols. So you've already said sort of around 2 months.
Yes. Yeah.
That's generally when I look at as well.
Because
the majority has happened at sort of 2 months, give or take, hasn't it? So then you said Oofy gel hard. So just sort of go through that with us if you can. Do you use anything to test it? I quite like to do the silicone again and see where it all ends up, and then you can just sketch around that with your scalpel so you know where it's going, and easier to then not have too much in there. You can visualize it, right?
Absolutely. Yeah, it is. So I just a light body silicone check and just see how much space there is, and then that gives me an idea on how much Oofy gel to put in. Because I don't want it spreading. The palate doesn't go anywhere. The vault of the palate, high up. The resorption does take place on the lower down, the alveolar process on the lingual aspect too. So it shrinks both sides like that. So, but it's quite nice. It really is nice looking at that, how much space we've got, and then mix it up, put it in, seat it, and if it's a partial, it is absolutely crucial to, whilst it's setting, I think it's about 2.5 minutes in, start to move it in and out if it's a partial, because it will just set and lock into the undercuts otherwise, and then it really is a problem.
It's too retentive.
Yeah, so you've got to drill it out, so it's horrible.
And then swells, that's the next bit. Speaking of drilling out, then, if you're looking at your hard reline, you're saying around 4 months, or your lab reline?
Lab reline,
around
4 months, yes.
How are you then looking at removing that Oofy gel, or if you're using a Visca gel? How are you going around doing that?
Yeah. So I don't remove it at all, because it makes it more if I start faffing with a fitting surface, it's just a waste of time. Totally. All I'd need to do is to paint. Well, first of all, say we're at 4 months now. We've got Oofy gel and the partial denture together like that. There'll be a space underneath the Oofy gel. I'll double check how much space there is, number one. And then secondly, I peel that off and then put my adhesive on that area, and sometimes I'll use light body silicone, sometimes I'll use zinc oxide eugenol, on that fitting surface. So it just goes in, fit it nicely in. So, and then make sure I board and mold, so it's not going over the frenum anteriorly. Wait for that to set, and then I do an over impression, a really good over impression of the whole arch in an alginate to pick the whole thing up. So that's my protocol. That goes through to Rowan, and then
I see where you're very lucky to have him next door. You get the extra fast turnaround as well.
Yeah, yeah.
And then you come round to definitives at 9 months or whenever it is. So I think we've covered everything that we want to cover there. So that's pretty good. Did you have any other bits that you wanted to show presentation wise?
I think that's. I think we've pretty much.
I think we've done it.
I think we've done it. Yeah.
Shall we open it quickly to the floor and see if we've got any questions from the lots of people that have tuned in tonight? So thank you, guys. So yeah, if you've got any questions, please chuck them at us now, and we can go through any bits that we haven't covered yet. But particularly with these immediate cases, the ones that you've shown are all on your resources, I believe, because I'm pretty sure I've seen all of them in either a lecture or a resource or both. So make sure you go and check those out, because there's tons and tons of stuff on there. Whilst we wait and see if there's any last questions, I do like to ask everyone one little thing about, is there something that you do now that you wish you knew earlier, or like a tip for younger dentists starting out? Doesn't have to be about immediates, but go for it.
I think the main thing is to get really good results in terms of, particularly I think communication is just absolutely key. In terms of like really clear communication with the patient, so they fully understand what's going on. I think we've got to be really, really honest with the patient. So it's and understand what they're really wanting. Great communication with the technician and great communication with your dental nurse as well. So that team, I think the dental nurse is just so really, really important in this whole mix too. So it's really good communication there. That's in terms of really helping with doing the sort of clinical part of the dentistry. But I do think finding a mentor is absolutely key as well. I've had quite a number of mentors throughout my career, but latterly, and the person I've learnt just so much is Dr. Besford, John Besford. And so I still talk to him every week if we can. We do a Zoom call and we have an hour together. We're writing a book together at the moment as well, but we often talk about the book and then get sidetracked on clinical things. There's so many gems that I can. So I think there's so many really, really experienced dentists out there. And as a young dentist, I was just really cocky. I thought I knew everything. And then the more I did it and the more mistakes I made, the more I realized, gosh, there's people out there that have been through this, can help me. It could have really accelerated my learning, really. So I think latching onto a mentor is really, really important.
Any ideas on ways to find mentors and things like that? Is it necessarily someone local? Is it reaching out on forums? Obviously, that's maybe changed a little bit since you were looking for mentors. But
I think it's just, I think it's a bit. There's an element of luck to it, and right time, right place. And I think it's as soon as you recognise someone that you feel is going to fulfil that, who you think, wow, they are amazing, just knock on their door.
Mm-hmm.
Really.
And that can go from technician as well, because that's definitely something that I found with my technician, is he found me via here a few years ago. But he's a fantastically experienced technician who he's been doing it a lot longer than I have as well. So I'm fortunate with my mentor in the practice itself, but also from a technician's point of view. And we did have a little comment saying, fantastic presentation, especially informative from a lab point of view as well, because obviously you've got that lab on site and working with Rowan since the hospital, right?
Absolutely, yeah. I've worked with Rowan since '99, and I don't think I've really sort of extolled his virtues tonight as much as I should, because I really don't think that technicians get the respect that they deserve. They are equal with us as clinicians, and we've got to think of them as being like that if we're going to get really good results. So, and I think that if you find, this is really, really important. If you've got a technician, I think find yourself a technician at similar age to yourself is important. So, because then you can grow together and retire at the same time or whatever, so you're not needing to, you can actually learn together. I think that's really good. And that's how it's worked with me. And it's really just giving them respect, asking them opinion. What do they think? How could we do this? And also get them to come in and see the patient in the mouth as well. Look, if they see you working with that patient, it helps to give them an understanding of the difficulties that we have as dentists. Maybe getting a really good impression for someone that's got a gag reflex, or maybe is really anxious and scared, etc. But these sorts of things are really, really important. The technician is absolutely the key to dentures and prosthodontics generally.
And that comes back around to your first thing about communication, as you say. It's about Ricardo and I were on a video call once a week about all the cases coming in and what we're doing and how to approach it. And definitely technicians never want less information, they always want more. So that's why I always think is try and give them as much as you possibly can, and think, what else could I give them at this point to help them with that.
Definitely, yeah. And that's where the loom comes in too. They are amazing, particularly.
So you do that with Rowan as well?
Not with Rowan, because he's literally
next door.
but I do it with my ceramist. If I'm wanting to have milled guide surfaces and whatnot on crowns, then I can just really say, look, this is what I'm wanting to do, and then he can revisit it. Scott can relook at it, and so I do find it very useful too.
Perfect. I think we've covered up all the last questions. Well, Mike's just saying, don't let anyone know where you live because there'll be a queue around the door. I absolutely agree with that, Mike. But no, I think everyone's sorted there. For anyone who wants more information, we've mentioned your courses and resources. So where can people find all of that kind of stuff? Newsletter, Just let people know that.
Brilliant, thank you.
So finlaysutton.com, .co.uk?
Yeah, .co.uk. Yeah,
.co.uk.
Yeah.
So make sure you check that out. Finlay, thank you so much for coming on. This has been an absolute pleasure. So I was super excited / nervous for tonight, but we've had a fantastic response. So thank you so much for that. Good way to accidentally book you in for the 25th episode as well. We've got one last one. Have we got time? How can we differentiate the difficult personalities to treat or not to treat?
So that's a really brilliant question. I think it's listen to your heart. If you think, when you actually if that patient makes you really uncomfortable and nervous, then that it's really important to listen to it and not to listen to your ego, because you can really. It's not often that I do this, but if I do have a patient, I think I'm not going to fulfill their expectations. I tell them that, and
that's what you're saying to them. I don't feel I'm the right person to fulfill your expectations, or
no, I don't say that. I don't feel,
because it's a tricky thing to put across, isn't it?
Yeah, it is. I say I don't think I'll be able to fulfill your expectations. And
then you refer to Mike Gregory.
Actually, I'm a bit on the spot, Rupert. Sometimes I'm really blatant about it and just say, look, if I take you on as a patient, I don't think that I'm going to be able to fulfill your expectations, and I think it will be at the expense of our relationship together. Mm-hmm. And I think it'll be at my expense as well, in terms of my, it might be at the expense of my family and the people that I work around me, because I want to get great results. I want all of my patients to be a success, and I just don't think we're going to get that with you. Sometimes that spirals into not a great conversation, but it's better that having that conversation at the beginning,
cutting it there.
Yeah.
Perfect. Mm. Well, there we go. Solid last question. Thank you again so much, guys. And as always, all this is the replay and everything's on Instagram TV. So if you missed it or want to rewatch stuff, check it out. And maybe we can get you back on at some point for the 50th episode or something like that.
Okay, dokes. Yeah, cheers, Ruth. It's been a pleasure.
Cheers, guys. Have a great evening.
Bye-bye. Bye.
Bye.